Good afternoon, and welcome to the Johns Hopkins 30-minute COVID-19 briefing, where we provide live insights from the experts who lead our work at the Johns Hopkins Coronavirus Resource Center. For the next half hour, we'll focus on what you need to know right now about the COVID-19 pandemic and public health responses. As part of this briefing, we'll have an opportunity for live Q&A with our experts. We took a short break from these briefings in the first half of August, but we are back and will be offering these 30-minute briefings regularly on Fridays at 12 p.m. I'm Dr. Lainie Rutkow. I'm a professor in the Johns Hopkins Bloomberg School of Public Health, and I'm part of the leadership team for the Johns Hopkins Coronavirus Resource Center. We'll be providing answers in real time today, so please submit your questions in the box at the bottom of your screen. Today, I'm joined by three guests. First, Beth Blauer, who is Associate Vice Provost for Public Sector Innovation at Johns Hopkins University. She's going to give us an update about one of our newest efforts, the Pandemic Data Initiative. Then we'll hear from Dr. Jennifer Nuzzo, who's a senior scholar at the Johns Hopkins Center for Health Security and an associate professor at the Johns Hopkins Bloomberg School of Public Health. Jennifer will give an update about trends we're seeing in the COVID-19 data. Finally, we'll hear from Dr. Bill Moss, who is Executive Director of the Johns Hopkins International Vaccine Access Center and a professor in the Johns Hopkins Bloomberg School of Public Health. Bill will give an update about COVID-19 vaccines. I'm now going to turn to each of our speakers for a brief overview. Beth, first to you. Over the last month, we've unfortunately seen the Delta variant rapidly spread throughout the United States, yet many states are publicly reporting COVID data less frequently. What is the significance of these data reporting changes?
Thanks, Lainie, and thanks for having me on the briefing this week. It is quite significant. We have experienced something that we started tracking almost a year ago, where we started to see a slowdown of states that were sharing regularly updated public data. I'm going to start first with a little bit of an overview of where we are right now on our data. As you mentioned, Delta is increasing cases across the United States. For the last several weeks, we've seen very significant case increases. I can say that there is a little glimmer of good news this week, where the week-over-week case data shows only a 14% increase in cases, where last week at this time, when we were looking at the case increases, we are at closer to a 25% increase week over week. So we may be seeing a little bit of stabilization in the case growth, but Delta is still very, very much in our communities spreading. We also are seeing increasing hospitalizations as it relates to Delta and as it relates to COVID writ large, with Texas and Florida really being the lead there in hospitalizations. We have a significant amount of individuals that are hospitalized in Florida, and that number is significantly increased week over week. So we are keeping a very close eye on these states and the reporting. But getting back to the original question is that many states have kind of clawed back on their reporting. So I'm going to go ahead and share the most recent visualization from the CRC, the Coronavirus Resource Center here at Hopkins, just to give you a sense of those states that have started to really reduce their reporting cadence. So if you can see my screen, you can see that this is our most recent addition to our visualizations. You can find this if you go to the coronavirus.jhu.edu. It's one of the first visualizations that you'll see. It's on state reporting frequencies. And this is a map that shows us by state, based on each category of reporting, what states are reporting this data and how frequently. What we first started seeing was that many states stopped reporting over the weekend. These were manual efforts to collect COVID data. They stopped doing that collection over the weekend. And so we started to see a lot of states move from going from a 7-day reporting cycle to a 5-day reporting cycle. Now we're seeing even some states take more radical steps in reducing that to 3 days, and in some cases, 2 days, and obviously back down to 1 day. And it changes based on the type of data. So here you can see that there are cases. These are the states. The dark green represents states that are still reporting in at 7 days. And then the orange states represent states that have decided only to do 1 day of reporting. When we get to the mortality data, you can see it does shift a little bit from which states are doing that reporting. And then testing continues to be one of the areas where we are getting the least amount of reporting. Why is this important? Because we really need to know where surveillance is happening, and we really need to know who has access to that testing as we continue to fight this surge related to Delta. It's incredibly important that we know where testing is happening and where it needs to proliferate. And then vaccination data also, we have the ability to sort of dive deep into that data to see where we're getting regular reporting. And then we have a summary tab here at the end if you want to go through and see which states, based on just the data alone, you can access that data. So we're encouraging everyone to take a look at this. We also are encouraging all states, particularly now that we're seeing significant case surging, to go back to that daily reporting cadence so that we can really prepare our public health workers and workforces in our communities with the best data to make those most important local decisions.
Thanks so much, Beth. Really wonderful to get to see that visualization and know that it's now out for anyone to explore. Jennifer, I'm going to turn to you now. With cases and hospitalizations on the rise, the U.S. is in a less optimistic moment of this pandemic. So as we all prepare for fall, which for many folks means returning to the workplace or returning to school, what are your concerns?
Well, a lot of concerns. I mean, the first is something that Beth highlighted in terms of the overall case numbers. We are seeing, unfortunately, growth in cases, and that's not a great trajectory to be on. The fact of the matter is nearly all states are reporting sustained case increases, which makes those calculations that much harder. We are, of course, also seeing some heterogeneity in how much cases are increasing. And, I think for those return to work or return to school questions, a fundamental question is, how do we make this easier? Well, we do that, one, by bringing down our case numbers. There's lots of ways to do that. But critically, among all of the potential approaches is to continue to make progress in vaccinating eligible individuals. We are seeing the impacts of that in the data. Even though most states are reporting case increases, the case increases are considerably higher in the states with the lowest vaccination coverage. That doesn't mean that states that have higher vaccination coverage are truly safe. Anywhere that there's pockets of gaps in immunity, there is at risk for case growth, particularly with Delta, which will require a higher level of vaccination coverage to, truly stop the spread. But nonetheless, the places that we worry about most are the places with the lowest vaccination coverage. Unfortunately, we are seeing some encouraging signs that some of the hardest hit states are seeing an increase in vaccine coverage, which is encouraging. We are also, I think, seeing some encouraging news in the fact that the overall growth in cases in the US, as Beth said, appears to be slowing a bit. That is great news. I'd like to see more of that. I'm sure that's probably a mix of people changing their behaviors because they're concerned, as well as continuing to make progress in terms of boosting immunity. But really, we need to be making more progress because as we choose to come together, there will be more opportunities for spread. If the case growth continues to slow, I think it is possible that what we'll see is, the numbers may go back down, perhaps in the September, early October timeframe. But unless we make, considerable progress in vaccinating individuals, we could see a resurgence of cases later in the late fall, early winter, as we enter the holiday season. Because one of the things that we've learned about this virus is it tends to spread within social networks. And when we do things that change our behavior, like perhaps going to travel to see family members or others for the holidays, we could kick off another resurgence of cases. So it'll be really important to not take too much comfort in the slowing case numbers that we're starting to see, and make sure we continue to make important progress in vaccinating. I just want to point out that cases are one of our earlier indicators of trends. Also, testing is an early indicator of trend. And unfortunately, we need to make more progress in expanding our testing network. We have, over the last month, seen testing rise again after a fairly long period of decline in the overall numbers. It's encouraging to see that more testing is happening, but right now we have a test positivity number in the US over 10%. I mean, we haven't seen this high of a number since much earlier in the pandemic. And what that tells me is that we are not casting a wide enough net to find the infections that are out there. So it'll be really encouraging, particularly as we're thinking of, returning to work and school, that all places think about expanding testing options to make it easy for people who may have mild symptoms to get tested. I will tell you, as a personal anecdote, I needed to get tested recently. And it took me a long time to figure out where to go, that I could get be seen within the same day and get test results back in a reasonable fashion. I'm obviously someone who spends a lot of time thinking about these issues. And so if it's hard for me, chances are it's hard for a lot of other people. So I do very much encourage states and local jurisdictions to examine what testing options are offered and examine the accessibility of these options, both in terms of just location and hours of operation. But if there are any barriers like needing appointments or needing to show insurance cards or ID cards, we've seen at earlier points that can deter people from coming in to get tested. And testing is the first step in our surveillance in terms of understanding what's going on. Just wanted to hit one more point on hospitalizations and deaths. These are obviously lagging indicators, and we are still at very high levels. So I will expect to see continual increases in hospitalizations and deaths in the coming weeks. I hope, if our case numbers continue to stop accumulating as rapidly as they have been, that we might see a slowing in hospitalizations and deaths. But just wanted to highlight for people that we're still very much in this. And even though our numbers are starting to slow a little bit, we are still at high enough numbers that we haven't seen in quite a long time. So there is still quite a long fight ahead of us.
Thanks, Jennifer. Really helpful. And also I do wonder, from hearing you talk about testing, if it's hard for you to figure out, it's certainly hard for the rest of us. Before I turn to Bill, I want to remind our audience, please submit questions for our experts at the box in the bottom of your screen. I do see lots of questions coming in, and we'll get to them shortly. Bill, we continue to see this stark disparity with vaccine availability in the US and also a plateau in uptake. Yet at the same time, there are parts of the world with almost no access to vaccines. So what are the implications of this when we think about mitigation of disease spread?
Right. This is a huge problem, Lainie. The global inequities in vaccine distribution and access, and I'll come to that. I'm going to start off with the issue, the state of vaccine coverage in the United States. We have reached the halfway mark, where 51% of the U.S. population is now fully vaccinated, and remarkably, as we've commented on before, just 81% of those older than 65. And as I've said before, that's where we need to get with the entire population. But where we've stalled is those under 65. Only about 60% of those 12 and older who are eligible for vaccination, or 62% of those older than 18 are fully vaccinated. There's about a 10% differential between those who've received at least one dose and those who've received 2 doses. Again, remarkably, those over 65, 91% have received one dose. So we have a long way to go. This is kind of a glass half full, but a glass half empty. And as Jennifer said, there's a lot of heterogeneity across states and counties in vaccination coverage, and we are seeing the biggest surges in cases in those counties and states where vaccination coverage is lowest. There is some good news. We are seeing an uptick in vaccines administered. We're at about a 7-day average of 670,000. That's up from about 435,000 doses per day. That was about the nadir that we hit, but well down from the 3.4 million doses administered per day back in early April. The problems in the United States, so first, number one, number two, number three priority, getting the unvaccinated vaccinated. This is somewhat of an issue of access, although I think we've done the United States has done a great job in improving access to vaccines. We obviously still have problems with demand, and those people choosing not to for various reasons to be vaccinated. We've tried carrots and sticks, both incentives. We are seeing more vaccine mandates that may even increase further with a full FDA approval of the Pfizer vaccine. But I also think fear is playing a role now. And Jennifer mentioned the fact that in some of the states where we've seen some of the lowest coverage, we're seeing some of the greatest uptake in vaccines in the recent days. The other big unvaccinated population are obviously children younger than 12 years of age. We had originally hoped that we would see an emergency use authorization for children 5 to 11 years of age in September. It looks like that's going to be pushed back as the FDA has asked for the studies to increase the number of children who are enrolled, in part to follow for adverse events, particularly the myocarditis and pericarditis that was seen in some, particularly the young adult males. So we're expecting now perhaps an emergency use authorization for children 5 to 11 years of age in late October or early November. But the big news this past week, Lainie, has been the vaccinated. And obviously there's been a lot of reports, and perhaps not unexpected, breakthrough infections. But the big discussion has been around booster doses. And as many in our audience know, the FDA authorized and then the CDC recommended what I'll call a third dose of the vaccine for recipients of solid organ transplants and those with similar levels of moderate or severe immune suppression. This is really not a booster dose. It's trying to provide protection to those who do not respond to 2 doses. And the data show that some, but not all, of these individuals will respond to a third dose. But obviously the big news this week, the Biden administration announcing plans for booster doses. And the proposal was that this would start on September 20th, and that booster doses would be available to those 8 months or longer after they received the second dose. I just want to highlight that this is pending authorization from the FDA on both the safety and effectiveness of booster doses, as well as recommendations from the Advisory Committee on Immunization Practices and the CDC. So the White House does not set vaccination policy. This is a planning proposal, and we will have to await both reviews from the FDA, ACIP, and CDC on this. This applies to the individuals who've received either the Pfizer or Moderna vaccines. And I just wanted to briefly, Lainie, review some of the evidence that was presented at the briefing on Wednesday. Dr. Rochelle Walensky, the director of the CDC, outlined data, and I'll briefly mention some of the numbers here, but evidence of decreased vaccine effectiveness against infection over time, but highlighted continued high vaccine effectiveness against severe disease, and evidence of lower vaccine effectiveness against the Delta variant. So this is based on observational data around vaccine effectiveness, the key here being the decrease in vaccine effectiveness that has been seen against infection over time. And then Dr. Anthony Fauci, the head of the National Institute of Allergy and Infectious Diseases, presented the immunologic data showing that antibody levels decrease over time, that higher levels of neutralizing antibodies are most highly correlated with vaccine effectiveness or efficacy, that higher levels are needed for the Delta against the Delta variant, higher antibody levels, and that booster doses increase antibody levels by about 10-fold. And on that same day, the CDC published in the MMWR 3 studies. Dr. Walensky had presented the data on these. I'm just going to highlight some of the numbers very quickly. There one study, a large study, over 130,000 residents of nursing homes, showed that from the period, the pre-Delta period to the post-Delta period or during Delta period, vaccine effectiveness against infection, and that's important, against infection, decreased from about 75% to 53%. Another study published in MMWR from New York showed, again, from kind of a pre-Delta era to a Delta era, decrease in vaccine effectiveness from 92% to about 80%, but continued high effectiveness against hospitalization, greater than 90%. And then the third paper studied, published in that MMWR, again, a large multi-state study of hospitalizations, again showed consistent high vaccine effectiveness against hospitalization, even in some of the high-risk groups, older adults, those with chronic conditions, those who are immunocompromised. So one could, interpret this in kind of two ways. The vaccines remain highly protective against severe disease, hospitalization, and death. That's very important. What was seen in these studies, the White House also drew on data from Israel and other countries, is this decreased vaccine effectiveness against infection, and that includes mild and moderate disease. So how do we kind of interpret all of this? I think there are, I think the White House presented a reasonable argument. Again, we need to have authorization and recommendations. But what are some of the critiques of this? First, I think there's an assumption that a decrease in vaccine effectiveness against infection will translate down the line to decreased effectiveness against severe disease. And I don't know that that's necessarily true. Second, is the 8-month period reasonable? Any window period is going to be somewhat arbitrary. The Surgeon General, Dr. Murthy, addressed this question. There's some, but that is a somewhat arbitrary and time window. It could be longer. We don't know the duration of protection following the boosters. Dr. Fauci presented the antibody levels boosting, but we don't know how long they stay high. And then we are still awaiting more data for those who received the Johnson & Johnson vaccine. So the White House press briefing really didn't apply to individuals who received a single dose of the J&J vaccine. Now, what are the downsides of booster doses? Well, there could be side effects. I don't expect that that's going to be a big problem. But, one question is, should people who develop myocarditis or pericarditis after 2 doses of a Pfizer vaccine, for example, receive a booster dose? But I think the major concerns have been, 1, will it distract from our main goal of vaccinating the unvaccinated? And 2, these global inequities. And now I'm going to come back to your original question, Lainie, and the White House definitely addressed this question, but we no doubt have global vaccine inequities. Less than 5% of people are vaccinated in many countries in sub-Saharan Africa. The United States needs to do more to address this, and there are plans to do so. And I'm just going to end, Lainie, with my proposal that the U.S. donate 10 doses for every booster dose given in the United States to COVAX.
Thanks so much, Bill. Gosh, there's a whole lot going on. I'm now going to turn to questions that have been coming in from our audience. And Jennifer, the first one is for you. What's your current thinking in light of the contagiousness of the Delta variant about mask wearing? So indoors, outdoors, and should we be thinking about better fitting masks and not just rely on whatever cloth one we can find?
So I think mask wearing is helpful. It's most helpful for the people who aren't vaccinated. But of course, as we know, if just because you're vaccinated, you can still become infected. And if you don't want to get a cold and you don't want to spread it to others, which many people don't want to, particularly those with unvaccinated people at home, masks are a great tool. There's been a lot of emphasis on better and higher quality masks. I mean, certainly if you can improve the fit, that helps. I am a little bit more pragmatic about it and say that the best mask is the mask that you'll wear. And some of those higher quality masks, I think, are difficult for some people to wear. They're also expensive. So, again, when we talk about safety, it's always layered, and it's not just masks, it's avoiding, poorly ventilated indoor spaces, and, trying to keep distance. All those things that we were talking about in 2020 still apply here.
Thanks, Jennifer. And a second question for you. It seems like we're hearing a lot more about children and COVID. Are the numbers actually different? Has there been an increase in COVID infections among young children now versus earlier in the pandemic?
So yes, the absolute numbers are higher, but the absolute numbers are starting to scale with, the numbers are scaling with the adult cases. Certainly, when you look at the percentage of cases that are kids, it's higher because there are, more protection against the virus in older age groups that are eligible for vaccination. But it's important in terms of assessing the risk to kids to understand where kids might be getting it from. And what's really interesting is that when you see the rise in pediatric cases, again, it follows the overall rise. The kids are getting sick where the adults are getting sick. And it also seems to lag a little bit from the adults. So that means that adults who get vaccinated are not only protecting themselves, but they're protecting children, including those who are too young to be vaccinated. So again, critically important, let's get ourselves vaccinated to protect not only ourselves, but also our family.
Thanks, Jennifer. Bill, question for you. Can you talk us through the difference in the benefits of vaccination versus so-called natural immunity among those who know that they've had COVID?
Yes, people who had COVID actually, develop immune responses. The difference is that it's highly variable with natural infection. And there does seem to be a correlation that people who've had more severe COVID-19 disease have stronger immune responses to the virus. And that makes some intuitive sense that they're being exposed to more virus. But it's just variable. And it's much harder to predict. We know so much more about the durability and the effectiveness or the protection that's conferred by vaccines. And that's why the CDC and the recommendations continue to be that people who have had evidence of wild type infection with SARS coronavirus 2 still get vaccinated to protect them. I've seen some data that suggests that people who've had natural infection are at twice the risk of getting COVID-19 or reinfected compared to individuals who are vaccinated. Obviously, there's a lot of variability here, and I have no doubt that some people who've had natural infection probably have very good immune responses to the virus. But it's really that variability in the immune response, both in the magnitude of the immune response and in the duration of immune response, that just makes it very hard to predict whether those individuals are protected and how long they'll be protected. We know that with the vaccines.
Thanks, Bill. And we're just about out of time, so I'm going to give you the last word for today with this final question. When folks get the Pfizer booster, is it a different formulation than the original Pfizer vaccine, or is it actually like a third dose of Pfizer?
Yeah, that's a good question. Right now it's the same vaccine. It would be the same vaccine, meaning, and by that I mean the genetic code for the spike protein is based on that original genetic code back in January when the Chinese investigators shared that. But Pfizer and Moderna, and I believe Johnson & Johnson are working on reformulated vaccines where basically the genetic code for the spike protein in the vaccine is to match the Delta variant and not that original strain. But those are not available yet. So right now, when we're talking about these booster doses, it's the same vaccine.
Thanks, Bill. And we are right at 12:30, so I'm going to wrap with a big thank you to Beth Blauer, Jennifer Nuzzo, and Bill Moss for joining me today. And also a thank you to everyone who joined us, and especially to those who submitted questions for our experts to answer. This briefing will be archived and available on coronavirus.jhu.edu. As a reminder, we offer these 30-minute briefings regularly on Fridays at 12 p.m. Our next briefing will be on Friday, September 3rd at 12 p.m. As always, in each briefing, we'll focus on what you need to know right now about the COVID-19 pandemic, and we'll have live Q&A with our experts. I'll look forward to seeing you at our next 30-minute briefing. Until then, thanks and stay safe.